In this video, we will discuss carotid-cavernous fistula. A carotid-cavernous fistula is an abnormal arteriovenous communication between the carotid artery and the cavernous sinus, leading to raised venous pressure, and it affects the orbital structures draining into the sinus, leading to ocular and orbital manifestations. Pathophysiology. The clinical features result from venous congestion around the orbit, increased episcleral venous pressure, and reduced arterial blood flow to the cranial nerves within the cavernous sinus. Classification of carotid-cavernous fistula. Carotid-cavernous fistulae are broadly classified into direct and indirect types based on the pattern of arterial flow into the cavernous sinus. Direct carotid-cavernous fistula. Direct fistulae are high-flow shunts in which carotid artery blood passes directly into the cavernous sinus through a defect in the wall of the intracavernous portion of the internal carotid artery. Common causes. Direct fistulae are a result of trauma in 75%, including surgery. Spontaneous rupture of an intracavernous carotid aneurysm. Atherosclerotic artery rupture, which is more common in middle-aged hypertensive women. Spontaneous fistulae usually have lower flow. Indirect carotid-cavernous fistula, also called dural shunt. In an indirect fistula, the intracavernous portion of the internal carotid artery remains intact. Arterial blood flows through the meningeal branches of the external or internal carotid arteries indirectly into the cavernous sinus, and the clinical features are subtler than in a direct fistula, such that the condition may be overlooked. Common causes. Spontaneous rupture of an atherosclerotic artery or a congenital malformation is the usual cause and may be precipitated by minor trauma or straining. Connective tissue and collagen vascular disorders can be associated. Symptoms of direct carotid-cavernous fistula. Presentation may be days or weeks after head injury with a classic triad of pulsatile proptosis, conjunctival chemosis, and a whooshing noise in the head. Symptoms of indirect carotid-cavernous fistula. Indirect fistula usually present more insidiously with gradual onset of redness of one or both eyes due to conjunctival vascular congestion. Signs of direct carotid-cavernous fistula. Immediate visual loss may occur due to ocular or optic nerve damage at the time of head trauma. Delayed visual loss may occur as a result of exposure keratopathy, secondary glaucoma, central retinal vein occlusion, anterior segment ischemia, or ischemic optic neuropathy. Signs are usually ipsilateral to the fistula, but may be bilateral or even contralateral because of midline connections between the two cavernous sinuses. Marked epibulbar vascular dilatation. Chemosis commonly hemorrhagic, particularly in early stages. Pulsatile proptosis with bruit and thrill, both of which can be abolished by ipsilateral carotid compression in the neck. Increased IOP due to elevated episcleral venous pressure and orbital congestion, and sometimes angle closure glaucoma. Anterior segment ischemia characterized by corneal epithelial edema, aqueous cells and flare, and in severe cases iris atrophy, cataract and rubeosis iridis. Ptosis due to third nerve involvement. Ophthalmoplegia in 60 to 70% due to ocular motor nerve damage from initial trauma, an intracavernous aneurysm or the fistula itself. The sixth cranial nerve is the most commonly affected because of its free-floating location within the cavernous sinus. The third and fourth nerves situated in the lateral wall of the sinus are less frequently involved. Engorgement and swelling of extraocular muscles may also contribute to defective ocular motility. Fundus examination may show optic disc swelling, venous dilatation and intraretinal hemorrhages from venous stasis and impaired retinal blood flow. Vitreous hemorrhage is rare. Signs of indirect carotid cavernous fistula. Milder epibulbar vascular dilatation than with a direct fistula. Exaggerated ocular pulsation, which is readily detected on slit lamp applanation tonometry. The presence of corkscrew epibulbar vessels is a common subtle later sign. These are not pathognomic and can be found in normal eyes. Raised intraocular pressure, often bilateral but higher on the side of fistula. Proptosis and bruit are mild if present. Ophthalmoplegia caused by sixth nerve palsy or swelling of extraocular muscles in marked cases. Fundus may be normal or manifest moderate venous dilatation with later tortuosity. Investigations. CT and MRI may demonstrate prominence of the superior ophthalmic vein and diffuse enlargement of extraocular muscles, though these may only be visible with a direct fistula. Orbital Doppler imaging may show abnormal flow patterns, particularly in the superior orbital vein. Definitive diagnosis may involve selective catheter digital subtraction angiography, especially in mild dural fistulae, though CT and MRI angiography can be useful. General principles of treatment. Ocular complications may require specific measures in addition to treatment of the fistula itself. Neurological specialist opinion should be sought at an early stage, even if features are mild, as some fistula patterns carry a high risk of stroke. Treatment of direct carotid cavernous fistula. Most carotid cavernous fistulae are not life-threatening. The organ at major risk is the eye. Surgery is indicated if spontaneous closure does not occur. A post-traumatic fistula is less likely to close on its own than a spontaneous fistula because of higher blood flow. Transarterial approach to repair the artery or occlude the involved sinus with coils or balloons. Craniotomy for arterial repair is occasionally needed. Treatment of indirect carotid cavernous fistula. Transvenous occlusion of the involved sinus. Spontaneous closure or occluding thrombus sometimes occurs in 50% of the cases. Intermittent carotid compression under specialist supervision has been reported to increase the likelihood that this will take place. To summarize, carotid cavernous fistula is an arteriovenous shunt between carotid artery and cavernous sinus. Direct fistulae are high flow and post-traumatic. Indirect fistulae are low flow and spontaneous. Pulsatile proptosis with bruit is a classic feature. Raised intraocular pressure due to episcleral venous pressure. Sixth nerve palsy is common. Dilated superior ophthalmic vein on imaging. Digital subtraction angiography is the gold standard.